CEO, Institute for Globally Transformative Technologies, Shashi Buluswar.
If we turn the clock back 15 to 20 years, the world was facing this horrible specter of HIV/AIDS. There seemed to be no real solution on the horizon. It's fair to say that today, in 2014, we are winning that war. A long, long way to go. And it is my great honor today to welcome someone who's been the front lines of that battle. Michel SIDIBÉ is the head of UNAIDS. And what I'd like to ask him from the perspective of UNAIDS is, what were some of the things that worked? And what are some of the challenges that remain? And how do you think those challenges should be addressed?
Thank you very much. Let me start by just saying thanks to Richard, Atias, and Cecilia, because I think this platform they are offering to us is one of certainly the most advanced platform I've been involved in Africa for a long time. It is a platform which is giving us opportunity to exchange, but also to learn from each other. Coming to your point, I think the last 2-3 days, we have been using the word partnership, innovation, transfer of technology, learning from each other. I think that is the core element of the success of the fight against HIV/AIDS. Without innovation, we would have been nowhere. Let us imagine a few years back when our hospitals were full of people sick, of people with HIV/AIDS, where we were not having hope. Everyone was scared of each other. We were not having any drugs to treat people. I think it's innovation which brought all the change. We have been able to push the people, the scientists, to become activists for the first time, to bring their knowledge and make sure that we can produce the first drug. The first drugs, when it came, it was 18 pills a day. You have to remember. And we changed completely this pattern. And today we're talking about 1 pill a day, and soon it will be certainly 1 pill every 3 months, every 4 months. That's make completely a change or our way to treat people. 50,000 people on treatment a few years back in Africa. Today, 9 million people on treatment. We were not even able to think 1 second that we could stop the transmission from mother to child. Is innovation again. We have been able to found a treatment which could be given to pregnant women and stop the transmission from mother to child. And today in Africa, we can soon announce by 2015 that we have a generation free of HIV/AIDS. Those are the type of transformation we have been seeing because of innovation. And I want to say that it's not just about treating people, putting people on pills, but what has been happening is even more than that one. Because of innovation, we change completely the dynamic of accessing to the price. The price is very important. If it's costly, if you cannot pay, if it's not affordable, how you will be able really to go for universal access for treatment or for health, for global health, is not possible. So because exactly this innovation, the price came from $15,000 per year per person to $80 per year per person. And that is because also we have been able to create those generic producers who have been able to produce generic drugs from India, from different parts. But what Africa needs today is to really break the dependency. It's not acceptable that in 2014 we still have 90% to 85 to 90% of our people on treatment based on medicine coming from India. Thank you to India. We are very happy that India is capable, but let us not forget that 30 years back, India was also dependent 80% to the medicine coming from abroad. Today, India is the third pharmacy of the world. So Africa can do the same. We can transfer the competencies, we can produce medicine, and we have to know that the medicine will be certainly one of the biggest business in the future. 10 years down on the road, I can say with confidence that the market of medicine will be $1.3 trillion. And today, Africa is only $6 billion out of that medicine. We are not producing, for example, condoms for our people. Today, we have only 6 condoms per person per year. But if you just think 1 second from where the rubbers are coming, rubber trees are in Africa. Let us produce our condoms. Let us make sure that we can be also creating space for all those things. So also, we saw that innovation didn't come just in terms of medicine and production of technologies and others, but we saw countries like Rwanda, countries like Ethiopia, transforming completely their health system, training in Ethiopia 35,000 community health workers, creating jobs for those people, and using mobile phone, like in Rwanda, to reinforce completely their health insurance, their health system data collection and analysis. Those are the type of innovation we can be able to do.
Wonderful. Let me now invite 2 other gentlemen working on the front lines of innovation in global health, Allan Pamba from GlaxoSmithKline and Denver Phiri from GE. Welcome. So let us go back to what I said about turning the clock back. At the turn of the century, there was this massive global effort to fight the big infectious diseases, HIV, AIDS, TB, and malaria. And as we heard, we are making significant progress. But now, 14, 15 years down the road, there is a realization that that old model has to evolve, that old model with focus on just the big diseases and with enormous dependence on aid and donor funding. Now there's a recognition that we need to move beyond these big diseases and focus on things like chronic diseases, diabetes, heart disease, and so on. And also, very much improved ways of thinking of mother and child health. We're also recognizing that the only way to really reach sustainable scale is through private sector models. And so to that extent, it's wonderful to have representatives of 2 very innovative and important companies that are fighting this battle. So Allan, let me get started with you. How does GSK think about the market, if you will, in Africa, and how you can think about the pharma market and how you can develop and sell pharmas in a sustainable way?
So, Shashi, if you allow me, I'll digress a little bit because, I came to this conference to be inspired, and I really have been inspired, especially by, the young guys who just left the stage, So, there was a question which was asked, and I'm going to speak both as an African, but also as an employee of GSK, because I think we're all in this together. There was a question which was asked, which is where should we focus our investments in the continent? There's a lot of focus now in building roads, bridges, etc. But my personal view is we need to invest in our people. We have a population of 1 billion. Average age is 19 years. Very young population. That demographic dividend needs to be translated into doctors, nurses, chemists, inventors like the ones we just saw, through investments in 2 key areas, health and education. Now, starting off with education, the only way we're going to get value creation coming back into the continent is when we have an educated population, where you can set up factories, you can set up production, and you've got people who will translate whatever you're doing into great value. So we need to really invest in education. Now, health is also very important. I think the reality is, even as we are seeing Africa undergo this economic revolution that we're all talking about and all celebrating, Africa has to solve 24% of the global health burden with just 3% of the global health workforce and only 1% of the global health budget. A huge challenge. If you've ever been on the back end of that statistic, It is not amusing at all. And I'm glad Michel SIDIBÉ has touched on the HIV epidemic. I was a young physician when this started off, coming out of medical school. 80% of the beds were occupied by patients dying from AIDS. And as a young physician, I probably signed more death certificates from HIV and malaria than I should have. These diseases have a huge economic cost to the continent. Malaria alone costs the continent about $12 billion. If you were to control it, that is money that comes back to us. So we need to make investments in education and in health. Now, specifically to the question that you asked about how GSK approaches Africa, I think one of the things that I wanted to make, one of the comments that I wanted to make is that when I look around the room and I look around most of us sitting in the panels, we have spent quite a bit of time working in the diaspora for blue chip companies, big companies. Now, I joined GSK 10 years ago. I left Africa, went to a land where there's winter every so many months, the UK. If you live in the UK, it's probably one of the most miserable places you'd ever live in if you come from Africa. Now, I spent 10 years there basically trying to be the face of Africa in GSK. That was my purpose, because when I left Africa, I left a clinic with 300 patients suffering from HIV/AIDS and no medicines for them. And I thought there has to be a bigger purpose in my life than signing death certificates for these patients. So try and get to the source and try and articulate what the challenge is. 10 years on, I'm coming back home to Nairobi at the end of this year on a new role, requested by the company to really be the face of GSK in Africa, having raised the ambition for the company in Africa. So we've announced recently, we're going to put up 5 new factories in the continent. We're going to invest in the first ever non-communicable disease research lab dedicated specifically to Africa, recognizing where the challenge, the new burden that's coming our way, the new tsunami that's coming after the HIV epidemic. And we have implemented over the last 4 years an innovative business model that is focused on access. You cannot make big money as such right now in Africa in the pharmaceutical industry. But if you're patient and you want to grow with the continent, you're going to be big over time. And we've recognized that. So what we're doing with our business model, the focus is on volume of medicines and vaccines. How much volume can we get out there? How low can we go on our price to maximize on volume? We're reinvesting 20% of the profits that we make back into healthcare infrastructure, because that is a challenge that faces both government and ourselves. And I think those innovative business models are what we need to be able to turn the clock around. GSK is one company. It's not going to change the world for Africa, but it can lead by example, and hopefully others begin to follow.
Great. Let me now turn to Denver, another proud son of Africa from Zimbabwe. Absolutely. Your thoughts?
So, you know, the future of healthcare within the African space, to Allan's point, is in the people, right? We need to invest in people to get them to be able to provide the healthcare that is needed on the ground. And to that end, you know, at GE, we've been working on training midwives. We believe midwives are a key component of the health system. And, you know, typically any health workforce pyramid has got doctors at the top, and then there's a bigger population of workforce at the bottom. So we're trying to train midwives to use ultrasound to identify high-risk pregnancies. To that end, we've worked in Tanzania. We've proven the model. 98 hours over 10 days, midwives with no knowledge of ultrasound can now use the technology to identify these conditions and therefore refer to areas where those high-risk pregnancies can be dealt with efficiently. And you know, this is just the beginning. We think that as we you know, continue to work in Africa, as we to another point that Allan made, increase access through handheld technology, we can get to more patients in the most rural parts of Africa to provide that care. And whilst we're on that same topic of providing care in the most rural parts of Africa, at GE, we believe in a concept called reverse innovation. Some of you might have heard Jeff Martin mention it at the African Citizen Summit, the concept of providing a solution for a location based on the resources in that location, right? It's how the world needs to now provide solutions for places like Africa. The typical model was, you know, stuff is produced overseas, and then it is sent to Africa, and then it is tweaked some way to fit the market. But we think that by working the other way around, providing a solution for the place that this tool is going to be used is going to be the model of the future, and I think this is where we're working quite actively.
Great. Michel, you're sitting next to representatives of two of the most important companies in the global health space. Do you have any asks of them or any recommendations for them in terms of what they should do to help you fight the HIV/AIDS battle?
Oh, I think it's very important to hear from GSK and from GI because those are companies we need to start understanding how they operate and how they can transfer knowledge and technology. My personal view is that the research and development and innovation should not be taken hostage by rich countries. We need really to democratize the knowledge acquisition. And Africa should invest more and more on knowledge economy. I know that building infrastructure are very important, but if knowledge economy is not there, if you're not producing our own ideas, if you're not capable to really attract our young researchers to make sure that we have a research base which is focusing on our own disease and trying to transform completely the nature of the response, it will not be possible. Secondly, I am very happy because I work closely with your CEO and Andrew Whitty, and just 3 weeks or 4 weeks back, they started with this new initiative to transfer competencies, build labs which are first-class labs in Africa for dealing with non-communicable disease, but also identifying universities where they can really start investing on research and development. So that is very important. To just give you one good example why it's so important for us to think about technology which can be used by population, democratizing completely the solution of our problems. If you take, for example, the CD4 machine, this is big machines which are coming from abroad, from Western technology, very advanced, which will help us to take a blood and know if we can initiate a treatment. With this machine today, it will cost us just to know if 12 million people who need a treatment to start, it will cost us $1.2 billion just to know. I'm not just saying treating them. Most of the machine can operate only on urban cities. And I was traveling, visiting a center in Melbourne just a few months ago. They just found a small test, and you take the blood, in 3 minutes, you can know if you can initiate the treatment. And with this test, which can be used at community level, with a community health worker going to the family level, will cost us only $50 million to initiate for 12 million people to start their treatment. Instead, $1.3 billion. So it is also saving costs. It is also partnering for building education system and research and development in our continent.
I have lots of questions, but let's turn to the audience. Questions from the audience?
Thank you very much. My name is Edna Allen Ismail, and what you have been describing is sheer music to my ears. I'm from Somaliland, a country that many of you do not know about, but there are people, and particularly women, who are having babies, and women who are poor, uneducated, and living in isolated places. Now, my education in the past had been in some of your most prestigious universities and colleges and hospitals. I was trained for a third world population. But when I went home to my country, there was nothing. That education that had been wasted upon me could not serve my people. And that was why I built a hospital. And how I can reach my people is to try and train midwives, community midwives, who can respond to the needs of 80% of our people, those who live in villages, those who live in distant locations, those who are illiterate, those who are malnourished, those who have been the victims of war and instability, etc., etc., etc. So, with midwives, we can put to practice all those noble aspirations of the Millennium Development Goals by responding to women's needs when they're pregnant, when they're having a baby, and after they have delivered, and also take care of their babies. Appropriate technology, which is appropriate to a developing country like mine, is very welcome. And that is one of the reasons I have pledged my life to continue to train midwives. And if God in His grace gives me time and life and resources, I would like to train 1,000 midwives for Somaliland and 1 million midwives for Africa. I would not be able to do that, but I hope many of you in this hall and elsewhere will take that pledge on and become ambassadors, goodwill ambassadors for your mothers, your sisters, your wives, and your daughters, because 80% of them are dying of causes that no woman in this day and age should die of. Train midwives, train midwives, train midwives. Thank you.
Thank you, Edna. So more than half the births occur at home. And if you combine that with the problem Edna is talking about around the need to train midwives, how do you think about that broader problem?
If I can just jump in real quick, Shashi, the point is exactly that. Pregnancies are a very defined process. We now know how it all works, but then we've also got things in place to make them successful. We've got ANC clinics that exist that women attend, and they tend to, the attendance rates are very high across the continent. And it is at that point where if you can identify those high-risk pregnancies, that you can remove the burden that would happen if they were to deliver at home. And this is exactly the vision that we've seen, and this is why we want to implement and impact at that level. Get them to the right place where they can get the right service, and then you can save a life of not only the mother, but potentially the child as well.
And I'm going to jump in and make 2 points. So one, exemplary. I think it's people like you that make meetings like this worth coming to. We don't just talk, but we do. So the midwives that you are training will make a massive difference for many of our population in Somalia. And you're clearly turning our demographic dividend, that 1 billion, 19 years average age, into something that translates into something very tangible. So well done for that. I think the other thing to say is that you'll be pleased to know that our company, GSK, made a policy 4 years ago that in the least developed countries of the world where we operate, we put 20% of our profits back into healthcare infrastructure. And we are putting that money on training frontline health workers. So, we're very focused on supporting the development of frontline health workers because they reach, where most doctors will never reach, So that's really good. I think the other point I wanted to make is it's really, and this is probably just a personal perspective, it's really important for Africa to begin to think very seriously about the upcoming tsunami I refer to of non-communicable diseases. We are sitting in our cars, we're sitting in our houses, we are drinking a lot more, we are smoking a lot more. We're going to get more cancer, more hypertension, and all the diseases associated with lifestyle. We do not have the infrastructure to take care of this. We do not have the specialists who will take care of this. It's not going to be another HIV/AIDS epidemic repeat all over again, which was basically dealt with a very philanthropic approach. Following the global economic downturn, there is donor lethargy. We need to be on top of this one. We need to find a way of paying a way out of this one.
Great. Thank you. On that thought, I'd like to actually take a segue and make a really exciting announcement, which is an idea that was hatched right here in Libreville last year at the New York Forum with my good friend Sam Thenia. We are launching the Universal Clinics Project with the ambition of building 10,000 clinics over the next 5 to 7 years to provide quality, affordable, sustainable mother and child care for Africa and for South Asia. And doing this in collaboration with Edna Adan Ismail, who has been called the Mother Teresa of the Muslim world, and Dr. Sam Thenia of Nairobi Women's Hospital. Let me now turn the mic over to them briefly to share thoughts on how they think we can pull this off. Microphones in front, please.
Thank you, Shashi. Sam Thenia, Group CEO, Nairobi Women's Hospital. Let me first of all ask at the end, UNAIDS, GE, and GSK, what have you done with the private sector? I do know that you've achieved a lot working with the private sector, but I'm just looking at what we've been discussing, especially focusing on healthcare, and asking myself, governments have limited resources. We would like to attract private investment into healthcare in Africa, because I do believe, coming from the private sector and running the largest private healthcare organization in East Africa, hospital chain, that we need to attract private investment. And what is your focus moving forward? But let me just go to what Shashi has just alluded to. Last year, at this forum, we met with Shashi, and we've been working on a model, we are calling it a clinic in a box. Basically, what we are looking at is that the challenge, especially of maternal and child health, is that there are so many gadgets that are scattered all over the place. They use different power sources and different voltages, and there is limited connectivity to the grid, especially in Africa. So the gadgets that we have assembled are mainly solar powered. The second problem that we have is that most of the gadgets in the market have been very expensive. So working in Shashi, we've looked and also developed gadgets, and we are able to put up a total clinic solution for mother and child for less than $10,000. And then this equipment integrated together on a same platform, we can use technology to collect data and transmit data. We can use the same platform for training, not just midwives, doctors, and other healthcare workers on the same platform. And above all, these clinics are going to be financially sustainable. So no philanthropy here. We are talking about private investment for the social good. And finally, we are modeling a hub and spoke model. So for example, in Kenya, where we are piloting, is that these clinics then have the backup of Nairobi Women's Hospital in terms of referral. And therefore, midwives who then identify the difficult pregnancies or have complications, then have a referral mechanism, both private sector driven and also public sector driven. So this is the innovation in healthcare that I do believe that Africa needs. And working with your organizations and other investors, I do believe that this is what Africa needs, not philanthropy, but private investment. I'll just ask my sister Edna to take up from there.
Grandmother. Well, thank you very much. I think what you're doing is commendable. You are in a place where you can do things like that. But then we need to think about those who cannot afford private health facilities and services. And when we train midwives, before we train midwives, we require that they come from where they will be working. For instance, if we have the map of the country and we know where the population density is, where we have health facilities and where we do not. It's where we do not have hospitals and doctors available that we find a group of girls to come and be identified from that location. If there's about 20 who wish to apply for training, we examine them and take the top 4 or 5. They're known by the community, they're trusted, and the commitment they have to make is that they will return to their community and their village and their town after training. That is my pound of flesh that they must commit to paying back. Once they are trained, we go back to the community and we discuss this with the village town leaders, because after training, These girls will be looking at patients, they will identify conditions that need to be referred, and if they do not have the support of the community, their efforts will fail. The government pays, the central government pays them, the local government provides them facilities, a health post, accommodation, water if it's available, and this becomes a public-private partnership with a community involvement and a community ownership. The midwives are trained first in general nursing, because we do not have the luxury of saying we will only respond to that emergency. Children will cough, they will have diarrhea, people will have fevers, there will be injuries, and there will be other ailments that will have to be identified. Many of those they can treat and they can manage. Some of them they will identify as being more complicated and needing to be referred to a second level facility, and they will do that in good time. Instead of waiting for 4 or 5 or 6 days, they will make sure that these referrals are made in good time so that the chance of recovery is improved. They become advocates for screening, whether it's for sexually transmitted diseases, whether it's to advocate for immunizations, vaccinations, environment, water, sanitation, nutrition, breastfeeding, and of course, fighting harmful traditional practices like female genital mutilation or female circumcision. So the 2 years that these girls are captive and they're in training, these are the attitudes and the practices and the skills that we pass on to them, and they actually become far more effective than having a hospital built which nobody trusts and nobody can afford to go and seek help from. So human value. And one last thing which is very important, young people, employment. Do you know that when you have a country's civil service, the largest number of employed people are in the army? The second largest number of people who are employed by any government are the health workers. You have the pharmacists, the nurses, the midwives, the doctors, the X-ray technicians. That is the second largest number of people who are employed by any government. Far more numerous than school teachers. Because in a school you will need 3 or 4 teachers. In a hospital you will need 50 or 60 staff. So train in health professions. Become a pharmacist, become a midwife, become a doctor, become a nurse, become a lab technician. And if you are also that way inclined, become one that trains others. So become a trainer of health care professionals.
Thank you very much, Edna, for that inspired speech. Thank you, guests. And we have a couple of announcements. Lunch is next door in the tent. And then the afternoon session, the closing session, starts promptly at 3:30.
Thank you very much.